guys, welcome back. This month I started with a lecture series on immunology, and in the last few lectures I have covered the basic immunology. From this lecture onwards, I will be covering primary immunodeficiency disorders. I will start with the basics and then will cover each primary immunodeficiency disease one by one. In this video, I am going to talk about the general features, the classification of primary immunodeficiency disorders, and would also discuss how to approach if you suspect a primary immunodeficiency disorder in a patient, which is usually a child. Just to remind you, all the lectures on immunology are grouped together in the channel playlist Immunology Made Easy. Do subscribe to my channel for regular updates. So let's start with the definition. The primary immunodeficiency disorders, they are a group of primarily single gene disorders of the immune system. Although there are hundreds of separate primary immunodeficiency diseases that have been described, but less than 20 account for more than 90% of the cases that have been found. Now, when do you suspect these primary immunodeficiency disorders? There are 10 warning signs of primary immunodeficiency that have been given by Jeffrey Model Foundation, and these points you should always remember. So, before listing all these 10 warning signs, there are 4 points majorly you should remember. That is, a patient of primary immunodeficiency will always have recurrent infections, and these recurrent infections, they are primarily of the skin, the oral cavity, the mucosas, and sinuses. Okay, and the infections, they're usually resistant to the antibiotics. There'll be few deep-seated infections which will lead to septicemia. And fourth, there is a family history that is present. So these 10 warning signs are based on the 4 basic points. So first is that there should be presence of recurrent infections. So there will be presence of infections of the ear, there will be infections of the sinuses, there will be infections of the lungs, that is pneumonias, there will be infections that are deep-seated or the deep skin or organ abscesses, and there will be infections of oral cavity and skin. Okay, so if infections, they are checked within 1 year. So 4 or more new ear infections within 1 year, 2 or more sinus infections within a year, then 2 or more pneumonias within a year, or recurrent deep skin or organ abscesses, and persistent thrush in mouth or fungal infection on skin, and 2 or more deep-seated infections including septicemia. These are the points of infections. Second is the antibiotics. But antibiotics, they're resistant to antibiotics. So 2 points. 2 or more months on antibiotics with little effect, and there is need for intravenous antibiotics to clear the infection. Now next comes the third point, that is deep-seated infections, which I've already discussed. I'll be covering in a different color. So 2 or more deep-seated infections during septicemia. Fourth point I said is that is presence of a family history. So a family history of primary immunodeficiency is usually present. Also, there is failure of the infant to grow or gain weight normally. Okay, apart from the pneumonias, because of the recurrent infections, there is failure of the infant to gain weight or grow normally. Okay, so these are the 10 points. There are recurrent infections, antibiotics, they have 2 or more antibiotics have little effect, and there is a need of intravenous antibiotics. The presence of 2 at least deep-seated infections, and a family history of immunodeficiency is present. Now, when a primary immunodeficiency is suspected because the patient has unexplained recurrent infections with opportunistic infections, then the patient is not responsive to antibiotic therapy, and there is failure to thrive, and the child is not gaining weight, then what we do is we check the family history of immunodeficiency. If the family history is present, then we immediately go towards screening from primary immunodeficiencies. However, if a family history is not present, then we can see for other reasons of the recurrent infections, like there can be presence of asthma, allergy, HIV infection, that is a secondary immunodeficiency, and then can be present there can be presence of cystic fibrosis. So if there is a reason other than the primary immunodeficiency that is present and we have found it, we can treat for that. And if not, then we then again screen for the primary immunodeficiencies. Now, most primary immunodeficiencies, they begin around 6 months of age. They appear around 6 months of age. Why does it happen? The reason is that the protective immunity that is afforded by the maternal IgG, which is passively transferred, this maternal IgG, it starts decreasing, and it is nearly by the 6 months of age, it is nearly depleted and is completely depleted by 1 year, that is 12 to 15 months, is completely depleted. So the IgG level in the infant body, it takes time to rise when after the maternal IgG it gets depleted. So between 3 months to 9 months around, there is a phase, that is a transient phase, in which the IgG levels are low. Sometimes this IgG levels low phase can be delayed, and that is known as the transient hypogammaglobulinemia of infancy, which is prone to infection. So this prolongation or extenuation of the physiologic immunoglobulin nadir that is normally observed during the first 3 to 6 months of age is called as the transient hypogammaglobulinemia of infancy. Right. Now, there are many definitions according to the immunologist, but the European Society for Immunodeficiencies, they have proposed that this transient hypogammaglobulinemia is a term that is unclassified for children, and usually this resolves or recovers by age 4 years. Okay. So, because of a decrease in the maternal IgG levels by 6 months of age, there appears a transient phase of immunodeficiency, and most of the primary immunodeficiency are also start beginning to manifest at this age, that is around 6 months, right? So the primary immunodeficiency disorders, they have been classified according to the component of the immune system that is affected. They are majorly of four types, that is defect in the phagocytic cells, that is the macrophages or the granulocytes, neutrophils. Then defect of the humoral immunity, that is defect in the B cells or the immunoglobulins. Then next is the defect of the T lymphocytes and severe combined deficiencies, that is deficiencies of combined T as well as B cells. And fourth is the deficiencies of complement system. But before listing all the diseases in the four types or the four categories of immune system deficiencies, I'll first discuss a few features of each type. So, first discussing the disorders of the humoral immunity, that is B cell differentiation defect or defect in the antibody production. As I've already told you that in an infant's body, by 6 months of age, the maternal IgG levels, they're almost depleted. Right. So the disorders of humoral immunity in which the antibodies, that is the immunoglobulins that are defective, they this manifest after 6 months of age when the maternal IgG, they become less. They can also present in adulthood because of some sporadic mutations causing a depletion of the B cell differentiation or antibody production. Now, the patients who have disorders of humoral immunity, that is, they have a lack of B cells or defective B cells and their antibody production is defective, those patients are more prone to develop infections by encapsulated bacteria. That is, three types: Haemophilus, Pneumococcus, and Streptococcus. So, encapsulated bacteria commonly cause infections in patients with humoral immunity defects. Also, they have tendency of infections with parasites like Giardia, Cryptosporidium, etc., thus causing gastrointestinal problems, and viruses like enterovirus, especially the patients with X-linked agammaglobulinemia, they have a tendency of developing recurrent gastrointestinal infection by enteroviruses. So they have recurrent infections of the sinuses, otitis media of the ear, and bronchiectasis. Also, they have chronic gastrointestinal tract problems, including malabsorption. Because of recurrent infections, they develop chronic gastrointestinal problems like malabsorption. There is also presence of associated autoimmune disorders. There's another entity called as post-vaccination paralytic polio, which is common in the patients of disorders of humoral immunity. The children who are given a live polio virus vaccine, they have a tendency of developing post-vaccination paralytic polio because of defective B cell differentiation and antibody production. They'll not develop an active immune response to the oral polio vaccine, but will rather develop the paralytic disease. Okay, so next we come to the T cell and mixed disorders, that is the combined B cell and T cell defects. Now, the child with any T cell defect is not protected by any maternal factors. So, any T cell deficiency or disorder will present before 6 months of age. And as just like with HIV or human immunodeficiency virus, which is prone to opportunistic infections due to the lack of CD4 T lymphocyte. Similarly, there is presence of opportunistic infections in primary immunodeficiency T cell disorders. Okay, so opportunistic infections can occur by various bacteria, viruses, and fungi. The most common including the Mycobacterium species, viruses including the Cytomegalo, Epstein-Barr virus, varicella virus, and enteroviruses, and fungal infections including Candida, Pneumocystis cerevisiae, etc. Now, these children, they usually present before 6 months of age, and they do not have a tendency to grow, that is, there is failure to thrive. Important point to note is that the children having T cell disorders, they have a tendency of developing graft versus host disease. That is due to the reaction with the maternal lymphocytes. So the maternal lymphocytes, when passed to the baby through the placenta, they developed a graft versus host disease due to the reaction with the maternal lymphocytes. These babies, they usually present because of the opportunistic infections by various fungal fungus like Candida, etc. Can present with oral thrush due to opportunistic infections by viruses like Cytomegalo, Epstein-Barr virus, enteroviruses, etc. They can develop diarrhea, which is excessive and not controlled by antibiotics, and also they develop post-vaccination disseminated TB. That is, if they are given BCG vaccination at birth, they will tend to develop disseminated tuberculosis or disseminated bacillus gamma-gurine infection. And also, if they're given live attenuated vaccine of polio, that is the oral polio drops, they'll develop a disseminated infection, and paralytic polio might set in. So these were the T cell or mixed T cell B cell disorders. Third is the phagocytic disorders. The phagocytic disorders is due to deficiency or defect in the phagocytes, primarily the neutrophils and the macrophages. So they can present from 6 months to 5 years of age, and the children with phagocytic disorders, they have a tendency of developing infections, especially by staph. So recurrent staph infections, the skin abscesses of the skin, the staphylococcal skin abscesses, they're usually very common. They also have tendency of developing infection by gram-negative bacteria like Pseudomonas, Klebsiella, Serratia, etc. So they have a tendency of developing infections from staph plus gram-negative bacteria. Children with phagocytic disorders, they also have tendency of developing fungal and parasitic infections. Fungal infections like those with Candida species and Aspergillus species, while parasites like Nocardia. These can cause infections in children with phagocytic disorders. So, important point, takeaway point is that phagocytic disorders, they have a tendency of developing recurrent staph infections and recurrent septicemia with gram-negative bacteria. So as I've said, they develop recurrent abscesses, skin infections, oral cavity infections, anorectal infections, usually by staph, and these wounds, they heal slowly. They have a poor wound healing. Also, in phagocytic disorders like chronic granulomatous disease, they have tendency of developing granulomas. These granulomas especially develop in the intestine and thus leading to the development of so-called granulomatous enteritis. Alright, so next entity we'll discuss is the complement disorders. The complement disorders, they can present at any age, and these patients with complement disorders, they usually develop meningococcal or gonococcal infections. That is, they have a tendency of developing infections with Neisseria. The patients with complement deficiencies, they usually have associated rheumatoid disorders or lupus-like syndrome, or disorders like scleroderma, that are autoimmune diseases, are associated usually with patients of complement disorders. So let us list all the disorders of the various components of the immune system. First, starting with defects of the phagocytic cells. These include leukocyte adhesion deficiency type 1, 2, and 3. It can include Mendelian susceptibility to mycobacterial disease causing infections with mycobacteria. The leukocyte adhesion deficiency, they cause infections with pyogenic bacteria. Remember, phagocytic cells, as we have learned earlier, that they have a tendency of developing infections by staph and gram-negative bacteria. Okay, only this disorder, Mendelian susceptibility to microbacterial disease, have a tendency of developing infections with mycobacteria. Chediak-Higashi disease is also a phagocytic disorder with recurrence of infection with staph and gram-negative bacteria like Pseudomonas. Next important disease to learn from the list is the chronic granulomatous disease. This is very important, uh, in which there is infection by staph species and staph aureus, and also recurrent fungal infections with Candida and Aspergillus species. Next, coming to the defects of humoral immunity, important diseases to remember are the common variable immunodeficiency, X-linked A-gamma-globulinemia, selective IgA deficiency, and B-cell SCID, that is severe combined immunodeficiency, that is B-cell type. Common variable immunodeficiency can be caused by a large number of genes and have susceptibility to infection with encapsulated bacteria. As I've already told you, that the patients with B cell disorders or B immunoglobulin disorders, they have tendency of infections with encapsulated bacteria, and the encapsulated bacteria are three types. One is Haemophilus influenza, Streptococcus species, and the third is the pneumococcus, that is Streptococcus pneumoniae, are usually common in common variable immunodeficiency, in which one or more of the immunoglobulin types can be deficient. Next is the X-linked A-gamma-globulinemia, in which all all the immunoglobulin types are deficient, and as mentioned, they can cause infection by encapsulated bacteria, as well as there can be infections with Neisseria meningitidis and opportunistic infections with pneumocystis, Jirovka, etc. Third is selective IgA deficiency, in which only IgA is deficient and the protective mucosal barrier is defective. And mostly these patients are asymptomatic but can present with uh, sinusitis, otitis media, and bronchopulmonary infections. The B cell type SCID, that is B cell severe combined immunodeficiency, have broad spectrum of infections which can include bacterial, viral, or fungal, and is the most important B cell gene defective is ADA, while it can present with other gene defects like RAG1, RAG2, AK2, etc. But most important is adenosine deaminase deficiency, which was the first gene that was discovered for causing a severe combined immunodeficiency. Now, as I've already discussed earlier about the transient hypogammaglobulinemia of infancy, point to note here is that this is an unclassified hypogammaglobulinemia according to the European Society for Immunodeficiencies, and this is actually described as the prolongation of the normal or physiologic immunological nadir. So at around 3 to 6 months, the maternal IgG levels they start decreasing, and it takes time for the baby's IgG levels to rise, right? The maternal IgG levels that have been given by the mother, they start decreasing by around 6 months of age. So this 3 to 6 months is actually a period in which there are low levels of IgG in the baby's serum, right? But if there is prolongation or extenuation of this low level of IgG period beyond the normal 3 to 6 months, then it is called as the transient hypogammaglobulinemia. This is actually the delayed onset of the normal IgG synthesis. It usually resolves, according to the European Society of Immunodeficiencies, it resolves by 4 years of age. In this period of low IgG levels, the child is usually susceptible to various pyogenic bacteria. In most cases, antibiotics are sufficient to treat the pyogenic bacterial infections occurring, but in severe cases, we can give gamma immunoglobulins or replace the immunoglobulins with IVIG. Okay. Next, coming to the defects of the T lymphocytes or the severe combined immunodeficiencies, that is a combined T cell B cell defect. So there's a large list of these defects. The most important are the DiGeorge, Wiskott-Aldrich, severe combined immunodeficiency, hyper IgE, and hyper IgM syndrome. Rest of the diseases, they are to complete the list. They are not usually asked in exams and they are not important to remember. So these include autoimmune polyindifferent syndrome type 1, ataxia telangiectasia, MHC class 1 and 2 deficiencies, Omenn syndrome, PNP deficiency, and CD3 gamma deficiency. Now, this DiGeorge syndrome is associated with various clinical manifestations given by the acronym CATCH22. So, 22 stands for the defect in the gene on the chromosome 22q11.2, right? And CATCH stands for C is for conotruncal abnormalities. Conotruncal abnormalities are the cardiac defects that are present. A is for abnormal facies. T is for thymus hypoplasia. Also, because of the thymus hypoplasia, there occurs T cell deficiency. Therefore, it is considered under the defects of T cell in the immunodeficiency disorders. So T stands for thymus hypoplasia or the T cell deficiencies. C again stands for cleft palate, and H stands for hypocalcemia or low calcium levels, right? Next is the Wiskott-Aldrich syndrome, that is characterized by infection by various encapsulated bacteria and is associated with the triad of eczema, recurrent infections, and thrombocytopenia, that is low platelet count. Severe combined immunodeficiency is because of a broad spectrum of defective genes. It can be of B cell, as I've already told you, among the defects in humoral immunity. It can also be T cell type or a combined defect and can cause broad spectrum of infections by bacteria, viruses, and fungi. Hyper IgE and hyper IgM syndromes are because of excess of one type of immunoglobulins, while rest of the immunoglobulins they become low, leading to various infections. Hyper IgM syndrome is because of CD40 ligand defect. So I'll be covering all of these immunodeficiencies which are important in detail in the subsequent lectures. So I'll be now going next to the deficiencies of the complement. So complement deficiencies, the most important is hereditary angioedema, age related macular degeneration, paroxysmal nocturnal hemoglobinuria. Okay, but the rest can include predisposition to immune complex mediated autoimmune disease such as SLE, predisposition to immune complex mediated autoimmune disease such as SLE and age related macular degeneration, MASP2 deficiency, MBL deficiency, etc. But hereditary angioedema is the most important here because of a defective gene of the C1 inhibitor that I'll be discussing in the later lectures. So now coming to the age, as I've already discussed you, the B cell deficiency or the defects of the humoral immunity, they usually present at 6 months of age, right? Because there is decline in the IgG, maternal IgG levels at 6 months, right? Or they can also present in adulthood. Specific diseases because of sporadic mutations they can present in adulthood. These include the X-linked agammaglobulinemia and common variable immunodeficiency. So these are the humoral deficiency disorders that present in more than 5 years of age or can present in adulthood, right? The T cell defects, I have told you that they usually present in less than 6 months of age. So the T cell defects like the T cell severe combined immunodeficiency, the T cell defects like DiGeorge syndrome, Wiskott-Aldrich syndrome, and X-linked hyper IgM syndrome, these present in less than 6 months of age. The phagocytic disorders, they usually present at the infancy period that can be anything. uh, Among them, the leukocyte adhesion deficiency that usually presents in less than 6 months of age, while the chronic granulomatous disease, Chediak-Higashi syndrome, and these syndromes they usually present in around more than 6 months to 5 years of age. While the complement deficiencies, you should remember they can present at any age. All right. So now we'll come to the various screening tests for the immunodeficiency disorders. For any T cell defect, we have to do the CBC. We check the CBC and the differential blood count. The differential blood count, they'll have a low absolute lymphocyte count. If a normal lymphocyte count is present, that rules out a T cell defect. Then we can do a flow cytometry to check for the naive T cells, that is presence of CD3 plus or CD45RA, cluster differentiation factors on the T cells and their T cell defects. At what level the T cell differentiation is affected can be detected. Next is the screening for the B cell defect. For the B cell defect, we check for the immunoglobulins levels. The immunoglobulin, we first check the IgA levels. If the IgA levels are abnormal, then only we go towards measurement of IgM and IgG, right? If the IgA levels are low, then only we go towards the checking of IgM and IgG levels. Antibody titers to protein and polysaccharide antigens like isohemagglutinins and antibodies to blood group substances, viral antigens can also be checked in specific disorders. Now, for the phagocytic cell disorders, we check the ANC, that is the absolute neutrophil count. If the absolute neutrophil count is low, then we can go towards categorizing it as at neutropenias. And usually the absolute neutrophil count is normal in chronic granulomatous disease. For those diseases, or it can be low in the myeloperoxidase deficiency, or it can be normal in G6PD deficiencies, right? So in these things we have to check the respiratory burst, and the respiratory burst assay is done where the neutrophil count is normal the ANC count is normal while the respiratory burst is defective. So, an ANC count will be low in neutropenias like the severe congenital neutropenia or the cyclic neutropenias, while it will be normal in chronic granulomatous disease, myeloperoxidase deficiency, and G6PD deficiency. Next, we check for the complement deficiencies. We check the CH50 that measures the intactness of the entire complement pathway. Low value, it indicates complement deficiency, right? We will discuss the confirmatory test for all the defects, the B cell, T cell, phagocytic, and complement in the subsequent lectures when we'll discuss the various immunodeficiencies one by one. Now, this is the algorithm we follow for a child who is having recurrent infections. If there's presence of recurrent infections, we see whether there's presence of bacterial infections or presence of viral and recurrent opportunistic infections. In case of bacterial infections, we see whether the bacterial infections are of pyogenic nature, whether they are of by the encapsulated bacteria, or whether there is a recurrent Neisseria infections like Neisseria gonorrhoeae, etc. Right. If there is presence of recurrent infections by pyogenic bacteria, that then it points towards the presence of defects in the phagocytes. Right. If there is phagocytes, they have recurrent pyogenic infections. Recurrent infections by encapsulated bacteria points towards the presence of a B cell defect or defect in the humoral immunity, while recurrent Neisseria infection point towards the presence of complement deficiency. Right. While the presence of opportunistic infections or the recurrent viral and fungal infections like persistent oral thrush or candidiasis point towards the presence of a T cell defect. Okay, so in case of presence of a T cell defect, we first do the complete blood count or the differential count, and there is presence of lymphopenia in that, right? If the lymphocyte count is normal, then it rules out a T cell defect. So there is presence of lymphopenia in the differential blood count. Also, we do the delayed type hypersensitivity testing and HIV testing in those patients. If there is presence of lymphopenia with absent DTH or HIV is negative, then we do the lymphocyte phenotyping or the flow cytometry. Flow cytometry is done. Also, mitogen antigen stimulation tests are done, and depending on that, we can do the genetic and molecular testing and the cytokine assays to detect which type of T cell defect is there. The lymphocyte phenotyping, it includes the enumeration of the B T cells and the NK cells, right? So if there is presence of lymphopenia, but the delayed type hypersensitivity reaction is negative and the HIV test is also negative, we know that it is a T cell defect, and we do the lymphocyte phenotyping to know which type of T cell defect is there. But if there is secondary immune suppression, like the HIV comes out to be positive, then we further do the CD4 counts, and we do the delayed screen for the opportunistic infections, and also initiate antiretroviral treatment accordingly. Then this was about the T cell defect. Now, if there's presence of recurrent bacterial infections, as here, that can be either pyogenic, encapsulated, or recurrent Neisseria infections, we do the complete blood count or the differential blood count. The complete blood count or the differential blood count is done to check the absolute neutrophil count. If the absolute neutrophil count is abnormal, that is either it is high or it is low. The high counts, if present, we have to repeat the counts, and we have to check for CD11-18 assay that detects a leukocyte adhesion defect. Right, this is in the presence of high counts. But if this presence of low counts, that detects a neutropenia. Low absolute neutrophil count or neutropenia can be present in various defects, including severe congenital neutropenia, cyclic neutropenias, or they can be presence of a secondary defect, like they can be presence of metaplasia or leukemias. So to check for these leukemias, we do a bone marrow biopsy. Next, after the complete blood count, we check the serum immunoglobulin levels. We check the IgA levels, and subsequently we check the IgM or IgG levels. So, if the immunoglobulin levels are low or poorly are absent, and antibody responses are absent, we then do the lymphocyte phenotyping. As I've told you, the lymphocytic phenotyping includes enumeration of B, T, and NK cells. So B cells, their phenotype will also be told, and defect in the B cells can be found out. After the lymphocyte phenotyping, we do the immunoglobulin G subclasses and the antigen stimulation and the genetic and molecular testing to know what type of B cell defect is present. All right. Next is the uh, serum immunoglobulin levels, if they are normal, and the neutrophil counts are also normal. So this is the third type in which the normal immunoglobulin levels are there and normal neutrophil counts are there. That means this is not a B cell defect, and neither can it be a neutropenia. So it has to be a defect of either the macrophages, the phagocytes, and it can be defect in the complement. To detect defect in the macrophages or the macrophage killing, like in the chronic granulomatous disease, we have to do the nitro blue tetrazolium test. Or to detect complement levels, we do the CH50 assay to indicate the intactness of the complement system. If these two are also not present, we have to suspect cystic fibrosis in the patient. Cystic fibrosis can be detected by the either sweat chloride test or the mucosal cilial biopsy, and we can do genetic and molecular testing to further diagnose the cystic fibrosis. So this was the algorithm which we follow in case there is presence of recurrent infections at a young age and we suspect a primary immunodeficiency in the child, right? So this was all about the primary immunodeficiency disorders introduction, and we'll be discussing first the defects in the phagocytic cells in the next chapter, starting with congenital neutropenias and then proceeding towards leukocyte adhesion deficiency as given in the list here. For listening to other lectures on immunology, kindly refer to the playlist on my channel named Immunology Made Easy. Don't forget to subscribe to my channel for regular updates. Kindly hit the bell icon for notifications. Thank you.